A young woman presents on the ward with sudden, hot, tender, red lumps running down the front of both shins. For many junior clinicians, the knee-jerk reaction is to label this presentation as bilateral cellulitis and reach for IV antibiotics. However, true bilateral, perfectly symmetrical cellulitis in an otherwise healthy patient is exceptionally rare. Skin infections do not typically organize themselves into neat, identical patterns on both legs. These clinical photos show the actual, definitive diagnosis, erythema nodosum, or EN. Erythema nodosum serves as a cutaneous siren, a visible alarm signaling a deep systemic fire. Administering antibiotics in this scenario treats the smoke while remaining completely blind to what is actually burning. While cellulitis infects the dermis, EN occurs deeper. It is an inflammation of the small venules within the subcutaneous fat, leaving the epidermis and dermis above entirely intact. The precise medical term for this deep fat layer inflammation is panniculitis. These lesions follow a self-limiting course, typically remitting within 6 weeks. Because the inflammation spares the top skin layers, the first absolute EN rule is that EN lesions heal completely without scarring. The second rule follows the same logic. True EN lesions never ulcerate. Since the skin maintains an intact epidermis and heals cleanly, the physician's duty shifts to investigating the systemic trigger. Once the clinical diagnosis of EN is secured, you must begin a structured systemic workup. When investigating potential triggers, this source confirms that the most common infectious causative organism worldwide is a streptococcal infection. The workup must also include a hunt for pharmacological triggers, specifically oral contraceptives, penicillins, and sulfonamides. In the absence of acute infection or new medications, you must consider chronic autoimmune associations like inflammatory bowel disease, specifically ulcerative colitis, and Behçet's disease. Finally, remember that pregnancy itself can act as the primary immunological trigger for an EN presentation. A meticulous patient history serves as the indispensable filter in decoding the systemic cause of the panniculitis. One specific mimic requires vigilance because a diagnostic error here carries life-threatening risks. Consider a patient with chronic, tender nodules on the calves that ultimately break down and weep. This technical source identifies these as ulcerated nodules, a hallmark of erythema induratum. The presence of ulceration is the definitive physical finding that rules out EN. The diagnosis of erythema induratum carries an essential etiological association. It is found in association with tuberculosis. Labeling these ulcerating lesions as EN means missing the critical window to treat active or latent TB. If the nodule ulcerates, it is not EN, and the clinician must immediately investigate for tuberculosis. For confirmed cases of EN, there is one mandatory imaging investigation required in every single patient without exception. Every patient presenting with erythema nodosum must undergo a chest X-ray. The goal is the exclusion of silent granulomatous lung disease, specifically looking for bilateral hilar lymphadenopathy. Finding these enlarged hilar nodes directs the differential diagnosis towards sarcoidosis or pulmonary tuberculosis. Asymptomatic sarcoidosis often hides silently in the mediastinum while announcing itself loudly on the shins. Because the definitive systemic answers lie within the chest film, an invasive skin biopsy is rarely required to manage EN. This constellation of findings leads to a specific acute presentation of sarcoidosis that removes the need for tissue biopsy entirely. The combination of erythema nodosum, bilateral hilar lymphadenopathy, polyarthralgia, and fever defines Lofgren syndrome. This tetrad has a 95% specificity for sarcoidosis. This high diagnostic confidence allows for a definitive diagnosis of sarcoidosis without invasive tissue sampling. Note that the polyarthralgia in this syndrome classically targets the ankle joints. Recognizing Lofgren syndrome allows the physician to move immediately to delivering definitive care. When facing these symptoms, patients often assume that painful, acute skin nodules indicate a severe, deteriorating systemic condition. However, in sarcoidosis, skin manifestations present a paradox. This source notes erythema nodosum is associated with a good prognosis, signaling a self-limiting disease course. This contrast becomes clear when looking at factors associated with poor prognosis, specifically lupus pernio. Lupus pernio consists of hardened, purplish facial plaques, signifying chronic, progressive, and dangerous fibrotic organ involvement. By identifying the panniculitis, refusing the cellulitis trap, and mandating the chest X-ray, you can leverage this alarming rash to provide a reassuring prognosis.